Hit the subscribe button or visit us at auau.auanet.org.
All right, I think we're going to go ahead and get started. So I have some mandatory housekeeping notes to review to start out with. This course utilizes the audience response questions. To participate, you will need to scan the QR code located on handouts near the entrance to the meeting room or on the screen. The AUA 2023 Annual Meeting mobile app is available and is free to download. When you download the app, you will be asked for a username and password. Course materials are available on the AUA 2023 website and mobile app. Use your email that you use to register. Your password is your AUA ID. You can find it on your registration badge. I'd like to welcome everybody. I am Kostas Lalas. My speakers today from the Greater Jefferson Enterprise are Ann Calvaresi Lizardi, who is presenting the APP program over the weekend, and Ed Trabolsi, who is the new chairman of urology at Einstein. The AUA policy states that all planners, authors, and presenters must disclose prior to their presentation all relevant financial relationships with any commercial interests. These disclosures are posted on the AUA's annual meeting website for easy access. Please visit www.auanet.org/annual meeting. Please remember to silence your cell phones. No photos, video, or audio recordings are permitted. Courses are selected based on evaluation results. For every course evaluation that you complete, your name will be entered into a drawing for complimentary registration for the AUA 2024 in San Antonio, Texas. You can evaluate this session by either selecting Evaluate through the credit claim process or going to the AUA 2023 mobile app, click on the CME button, or go online and click on the CME page. That being said, the course is Chemotherapy and Immunotherapy for the Urologist and Advanced Practice Provider. If you are in the wrong course, now is your chance to get out. Like I said, I'm Kostas Lalas. We also have Ann Lizardi Calvaresi, and Dr. Ed Trabolsi. The learning objectives are as stated. I'll give you a second to go through these. And here is the QR code to participate in audience polling questions during the presentation. And I'm going to go through those questions now. Question number 1. Which class of agents serves to block downregulation of T cell activity and leads to an enhanced immune response? And those are the answers. Go ahead and enter your answer. All right, we'll go to pretest question number 2. A 68-year-old male undergoes neoadjuvant cisplatin-based chemotherapy followed by radical cystectomy for muscle-invasive bladder cancer. On final pathology, no residual disease is noted. How does this impact his long-term outcome? I'll give you a second to enter your answer. Question number 3, a 62-year-old female presents with metastatic renal cell carcinoma and is classified as IMDC poor risk. Which immunotherapy regimen is considered first-line treatment for this patient? And your answers are below. I'll give you a chance to enter your answer. All right, let's move on. Number 4, a 72-year-old male with advanced prostate cancer is being considered for treatment with sipuleucel T. Which of the following disease states is approved for utilization of this medication? There are your answers. Go ahead and enter your answer. All right, let's move ahead. Question number 5. Which of the following agents has been approved for use in postoperative patients with locally advanced clear cell renal cell carcinoma that has been completely resected? There are your answers. Go ahead and enter your answer. And finally, question number 6. Which of the following is a proposed benefit of relugolix over the standard ADT options? There are your answers. Go ahead and enter your answer. Okay. Let's go ahead and change the slide deck over to our presentation. As I mentioned, the course is Chemotherapy and Immunotherapy for Urologic Malignancies, a primer for urologists and advanced practice providers. Our speakers are Ann Lizardi-Calvaresi, myself, and Dr. Trabolsi, all coming from the Jefferson Enterprise. Here are our disclosures. We're going to split this up in 3 sections: prostate cancer, bladder cancer, and kidney cancer. Prostate cancer will be presented by Ann. Take it away.
Good morning. All right, so getting started with prostate cancer. I'm sure you've all seen this. This is a classic representation of prostate cancer when it's diagnosed in its localized form, treated with surgery or radiation plus or minus androgen deprivation therapy. You may see a recurrence with indicated biochemical recurrence, at which point ADT is utilized, and then as you move forward into the castrate-resistant disease state, advanced systemic therapies are used. This is very historic, and we're going to see why it's a little bit outdated as we move forward. And so moving on into the traditional hormonal ablation therapy, the GnRH agonists, they stimulate the LH and FSH from the pituitary gland to the testis. It's a negative feedback system, kind of like your home thermostat on a super hot day when it gets really, really hot and eventually it just stops working. This is kind of what happens with the testosterone release when patients are on this. Patients reach castrate levels at about 4 to 6 weeks after initiation of treatment. Most common agents in this drug class are leuprolide. You can see a T surge when you give this, so you may need to use an anti-androgen to block that T surge. The GnRH antagonists, they directly inhibit the pituitary LH and FSH release, so there's no surge in the androgens. The most common agents here are dagarelix, which requires a monthly administration, so it's a little bit less convenient for patients and providers. And we have the new oral GnRH antagonist called relugolix, which gives some patients a little bit of autonomy. They're not getting injected. They feel like they have a little bit more control. And we're going to see another benefit here. So you can see you get basically the same level of castration, but a quicker return of testosterone to normal levels when they stop the medication compared to an injection. Additionally, there are fewer cardiovascular side effects for patients who are on the oral therapy versus like a dagarelix. The traditional hormonal therapy includes the nonsteroidal anti-androgens. They block binding of the androgen to the androgen receptor. Most common drug class here is bicalutamide. It's important to monitor LFTs in patients who are receiving this medication. So I usually order them about a month after they start medication, and then obviously, periodically throughout. We don't commonly see orchiectomies any longer, at least not in the States. Here, you can see where these medications, mechanism of action occur. Duration of hormonal therapy really varies. So in patients who are diagnosed with intermediate risk prostate cancer and they're going to be receiving concurrent radiation therapy, they usually are given 6 months of androgen deprivation therapy. Sometimes we'll see 4 to 6 months. In patients who are diagnosed with high-risk prostate cancer and who are going to be undergoing radiation therapy, they're usually prescribed 2 to 3 years of ADT. And then in patients who have biochemical or metastatic disease, they may go on intermittent or continuous therapy. This slide is probably my favorite slide of the deck, but also every time I place patients on ADT, I think about this while I'm talking about this potential side effects that they're going to experience. Sometimes I'll even draw it on the whiteboard in the exam room. So ADT in the middle, and I'll say, you're probably going to experience all of these side effects, at least to some degree. So hot flashes, altered body composition, cardiovascular changes, decreased bone density, metabolic syndrome, fatigue, and loss of libido, erectile dysfunction, and then cognitive decline, which I usually tell them is usually for patients who are on it for a longer duration. So metabolic changes, weight change, gynecomastia. I always tell patients that the best way that they can possibly mitigate this or decrease it to the greatest extent possible is healthy diet and exercise. And I'm going to kind of hit on this on the next following slides. That helps with their sleep pattern as well. So for cognitive decline, specifically verbal memory, visual motor function, attention, and executive function, so a lot of patients will note that their attention is altered or decreased. So we want to encourage physical activity for this, but also mindfulness-based stress relief and mental stimulation. So, and especially in your elderly patients, say, get out of the chair, stop watching television, maybe some crossword puzzles, or at least reading, getting out of the house, getting some type of other stimulation. The altered body composition, metabolic syndrome, and fatigue. These patients should be followed closely by their PCP and their cardiologist if they have one. Closely followed serum labs, including their cholesterol panel, glucose, A1C. Again, strongly recommending daily exercise. And that includes cardiovascular exercise, but also some strength training. So I always tell patients, I don't expect you to go out and run a triathlon or a marathon, but even if they're used to sitting in their chair in the house, pick up a set of 1-pound dumbbells and use them for 5 minutes a couple of times a day. And say, Ann, I can't walk a block. That's okay. Get up and walk around your living room a couple of laps as opposed to just doing nothing. Again, healthy, well-balanced diet. If they're really unsure, you can send them to a dietitian. I always tell them to stay away from those center aisles in the supermarket. Shop on the perimeter, because that's where you find all of the healthier, more, the fresher products. Routine sleep cycle, that's also very helpful. So going to bed at the same time, waking up at the same time, staying away from stimulants or screen time right before bedtime is very helpful. Also, we think about these patients, a lot of times they're getting up to pee very often through the night. Have them cut back on their fluids 3 hours before bedtime. You want to manage their BPH symptoms if they're present as well. Smoking cessation, of course, is very important. If they don't have a cardiologist, they would probably benefit by seeing one or at least being followed by one. We're looking here at a healthy diet. And the AHA and the American Cancer Society both have very loose dietary guidelines that you can refer them to. There's an increased likelihood for emotional lability and depressed mood, so you can consider antidepressants, individual counseling, couples counseling, support groups if they're available, and consider treatment of the ED. A lot of times these mood changes are really dependent upon the fact that they're not able to perform for their significant other, so if you can treat the ED, that's really going to help them in the long term. Unfortunately, we don't have any FDA-approved treatments for the hot flashes, but considerations here are acupuncture, vitamin B supplementation, which shows anecdotally, and it also shows in women, going through menopause that there's a huge improvement in their hot flashes. And then, we can use magistral acetate, also some SSRIs. But what I always tell patients is that if we're going to use those, most of them do have their own set of side effects associated with them. We worry about bone health, so this is like male menopause. When women go through menopause, we see osteoporosis or osteopenia, so we want to optimize their bone health and decrease the changes in their bone density as much as we possibly can. So at the very least, patients should be on vitamin D supplementation and calcium. There should be a baseline DEXA scan, especially for patients who are going to be going on at least a 2-year course of ADT, and then periodically throughout the treatment, they should be getting repeat DEXA scans. You're going to consider an anti-resorptive agent in patients who are higher risk, so you think about their elderly, the frail, smokers, or alcohol abusers. Anti-resorptive agents are very strong. You worry about osteonecrosis of the jaw for patients who are placed on these medications, so you want to make sure that they have a thorough dental evaluation before they're placed on these medications. They are approved for preventing and treating osteoporosis for patients who are on ADT. The bisphosphonate therapies, that's a zoledronic acid. It's given IV. This inhibits the bone osteoclast, so that you're inhibiting the bone breakdown. You need to worry about patients who have decreased renal function, so they need very close, careful follow-up with their creatinine. So you're, again, working very closely with their primary care physicians when patients are on these medications. Denosumab, it promotes osteoclast and bone reabsorption, minimizes skeletal-related events, and development of bone mets. So the dosage for bone mets is 120 milligrams subcutaneous, and for osteoporosis, it's 60 milligrams subcutaneous every 6 months. So you can see here, compared to that very first slide that I showed, all of the potential agents that we can use for patients with prostate cancer. And this changed dramatically even just compared to 3 years ago or 5 years ago. And some of these trials, so we've given this talk for several years now, and some of these trials I really went into deep detail with previously, but now we have so many that we would be here all day if we did that. So some of the more recent ones, we're looking at Titan, so that's apalutamide for patients with metastatic castrate-sensitive prostate cancer. This looked at over 1,000 men with metastatic disease, and they were randomized to ADT plus apalutamide or ADT plus placebo, looking at co-primary endpoints of overall survival and radiographic progression-free survival, and you can see that there was a huge improvement in patients who were on ADT plus apalutamide, and that's depicted here. So just in 2022, this looked at abiraterone plus prednisone added to androgen deprivation therapy and docetaxel in de novo metastatic castrate-sensitive prostate cancer patients. So this was looking at 1 to 1 to 1 to 1. And so obviously we haven't seen patients who have been given these this great number of treatments all starting at the same time. And the co-primary endpoints were overall survival and radiographic progression-free survival. And you can see the large improvement in patients who were on treatment. And again, so historically, so in 2015, we had docetaxel with the CHARTED and STAMPEDE trial. And then in 2017, we had abiraterone, and 2019, enzalutamide. And now we're looking at this triplet therapy, which we just saw in the prior trial that we discussed briefly. Here we're looking at darolutamide and survival in metastatic hormone-sensitive prostate cancer patients. So this looked at about 1,300 patients, looking at docetaxel with ADT plus darolutamide versus docetaxel plus ADT and a placebo. And it showed that patients who were on the darolutamide had a 32.5% reduced risk of death. And so again, this is how that very first slide has changed to this point. So we have all these agents available to us. I always tell patients we have an arsenal of things available to you, even in patients who are diagnosed with metastatic disease. So for non-metastatic castrate-resistant prostate cancer patients, so these are patients who have a rising PSA, a castrate level of testosterone, and negative conventional imaging. So usually CT, abdomen, and pelvis, and a bone scan. So some of these newer imaging studies that we're going to talk about briefly later, that's not conventional imaging. Those are some of the newer imaging studies. So NCCN guidelines for these patients include close observation, plus ADT. So there's category 1 evidence supporting apalutamide, enzalutamide, or darolutamide in addition to ADT. So that's actually recommended above ADT alone. And then you can consider second or third line hormonal manipulation. So based on the results from Spartan and Prosper, Spartan and Prosper both demonstrated metastasis-free survival in men who were on treatment. And this was the first time that this was studied for this endpoint. Apalutamide then was approved for non-metastatic castrate-resistant prostate cancer. This is a non-steroidal anti-androgen. You have to worry about hypothyroidism, skin rash, and fracture in this patient population. So hypothyroidism, you're gonna watch their thyroid levels. The skin rash is usually very well managed with topical corticosteroids and maybe an antihistamine. Very few patients, you can dose reduce, but after dose reduction and topical corticosteroids or oral antihistamines, I've had one patient who I've had to take off of treatment, and that was when he developed like an open weeping rash on the palms of his hands. Fracture. Of course these patients are going to have fractures, right? You're talking about older men who are less ambulatory, they're falling. So you want to optimize, number one, their posture and their mobility. So you're having fewer falls and you're having more fractures because you see decreased bone density. So again, physical exercise and improving their overall strength. So darolutamide, there's a little bit less crossover of the blood-brain barrier, so we believe that it's better tolerated. Aramis looked at this and showed improvement in metastasis-free survival and overall survival, and that's depicted here. So 2023 NCCN guidelines for metastatic castrate-resistant prostate cancer. So you want to maintain that castrate level, so you're keeping them on androgen deprivation therapy. Considering the bone anti-reabsorptive agents, either denosumab or zoledronic acid. For the patients who are asymptomatic or minimally symptomatic, you can consider Sipuleucel-Cel-T, and then palliative radiation therapy for painful bony metastases. This is a really busy slide. I put it up here only because I think that it's so important for all of us as providers to have an NCCN login. And I've spoken to a lot of nurses and APPs who don't even know that it exists, unfortunately. But I always tell them it's free. You can go on there, and it's basically like the Bible or whatever religious book you use. It tells you every single step of the way what to use and when to use it. So this is great. It's always available to you when you're seeing a patient, and I have it on the desktop, and I reference it very frequently. Sipuleucel-Cel-T is immunotherapy for prostate cancer. It's approved for non-visceral asymptomatic patients. It works by harvesting the T cells through leukapheresis. It's cultured and stimulated, and then it's reinfused 3 days later. It's given as 3 cycles, 2 weeks apart. The unfortunate thing is that it doesn't really decrease the PSA. So we talk about PSA anxiety. So patients get PSA anxiety before they go to the lab, the night before they come in to see you, and then while they're sitting in the exam room. So if they're on treatment and they're not seeing a PSA response, of course, it's not super, super helpful. The largest improvement was in patients who had the lowest PSA quartile, showed improved overall survival benefit compared to patients with a higher PSA. And so here you can see all of the approvals for metastatic castrate-resistant disease as of this year, and again, compared to 5 years ago or 3 years ago, we have many, many more options available to us. For patients with metastatic castrate-resistant disease, the first treatment was approved in 2004. This was docetaxel, and historically we didn't think that chemotherapy worked very well against prostate cancer. And then we had the AR-targeted therapies, which were approved just not that long ago, so abiraterone and enzalutamide. They were first approved post-chemo and then pre-chemo, which is really a space that we see them used often now. Abiraterone was also approved for metastatic castrate-resistant disease with or without visceral mets pre and post chemo. It's an androgen biosynthesis inhibitor. It's given 1,000 milligrams a day. The unfortunate thing is it has to be given with prednisone. You do worry about drug-to-drug interactions. We actually have a really wonderful specialty pharmacy who will look at their drugs, and even if I think they're safe, they'll say, oh, and they're on X, Y, and Z. At the very least, you need to talk to their primary care doctor or their cardiologist, and at the very least, you need to think about spacing them apart, so giving them 8 hours apart. Again, patients need to be followed closely, so LFTs, electrolytes, cardiovascular health. Consider dose reductions in patients who have liver disease. However, in severe liver disease, it is contraindicated. This is the follow-up schedule for patients who are on abiraterone. So nursing staff and APPs are in a vital role to be able to follow these patients more closely. Enzalutamide was approved for metastatic castrate-resistant disease with or without visceral mets pre and post chemo. It competitively binds the androgens and prevents translocation of the androgen receptor into the nucleus. This is given as 160 milligrams. I think we're good. And it's contraindicated in patients with severe hepatic impairment. You do want to use this with caution, so if patients have a history of seizures, you want to probably not use it. This also has drug-to-drug interactions, so either look at their drug list very closely, or if you have a specialty pharmacy, perhaps they could be very helpful to you. Also, you can consider reaching out to your pharmacist. We know that in patients who have pre-existing cardiovascular disease, we see an increase in cardiovascular events in patients who are placed on abiraterone and enzalutamide. So these are the, I'm not going to go into great detail on this slide, but you can see all of the ways that we can use these medications in the disease states, and the dosages are here as well. So I see a couple of people taking pictures. I think this is helpful, as you see patients in this in the clinic with these diagnoses. So chemotherapy, as I mentioned earlier, it was thought for a long time that it was not very effective against prostate cancer. Docetaxel was first approved, and it was indicated for patients with metastatic castrate-resistant disease who are failing other therapies. Cabazitaxel is another taxane chemo compound. It was approved in 2010 for metastatic castrate-resistant disease who had failed docetaxel, so this was second-line therapy. The radioisotopes naturally target new bone growth in and around the metastases. Most common drug here is radium-223. I'm sure you've all heard of that. And radium-223 demonstrated both symptomatic improvement and survival benefit in patients with castrate-resistant disease. It was given for a period of 6 months. So second-line treatments for metastatic castrate-resistant disease include docetaxel, enzalutamide, abiraterone with prednisone, alternative chemotherapy, pembrolizumab, olaparib, and clinical trials, which kind of leads us into newer directions. So we think about combination therapy, we think about sequencing, correct sequencing, gene expression testing, and then the other agents which we have listed here, including the PARP inhibitors. So gene expression testing, each of the following can be used for prognostic purposes. So Decipher looks at is an endpoint trained for looking for metastasis. Prolaris is the endpoint trained for time to biochemical recurrence and time to death from prostate cancer. And then Oncotype looks at endpoint trained for adverse pathology. And this is basically the same thing, but with a little bit more detail. And so what we're trying to weed out is, are these patients going to progress or are they not? And for the longest time, we didn't have additional testing that would help to determine that. But these tests are very helpful in weeding out which patients are going to respond to more aggressive therapy versus which patients are okay with monotherapy or traditional therapy. And you can see that most of these are covered by the, or indicated in NCCN, which means that they're usually covered to the greatest extent by commercial carriers, and they're all approved by Medicaid. And they're approved for most disease states. So while not approved for very low risk disease, they are approved for low risk, unfavorable intermediate risk, and high risk disease. PSMA PET, this I mentioned earlier. So we talked about conventional imaging, which is CT, abdomen and pelvis, and a bone scan. So now we have these newer imaging studies, which are very helpful in detecting patients who have, biochemical recurrence or potentially metastatic disease. And so what we're trying to find, do they have sites of disease that are not picked up on conventional imaging? So PSMA, it's a molecular target, and it's highly expressed in prostate cancer, including metastatic lesions. So it's helpful for us treating patients not with an undetectable PSA, who we don't think we're going to see. Of course, with an undetectable PSA, we're not going to see anything on imaging. But in patients who have negative conventional imaging and then a rising PSA, we would want to proceed with this. Also, it's not super helpful in patients who've got, obvious metastatic disease. So why don't CTLA-4 and PD-1 monotherapy work in metastatic castrate-resistant disease? Because it's a cold tumor. So we think about hot and cold tumors, the ones that respond better, and prostate cancer is not one of them. So novel directions in trials not yet approved, so vaccines plus PD-1, combination checkpoint inhibitors, targeted therapy plus PD-1, cytokines, and others. And then looking at the role of genetic testing in patients with prostate cancer. So the Philadelphia Prostate Cancer Consensus Conference was held in 2017 and 2019. So looking back to 2017, the agreement was made to test all men who presented with metastatic disease, no matter what age. And we're only just scratching the surface of germline mutations in metastatic prostate cancer. So, patients will say, well, do I have that? And I'll say, well, if the study says no, that doesn't mean you don't. It's just that moving forward, maybe if we test, the more information we have, maybe at some point we would identify a mutation. But we do know that BRCA2 is best studied, and we see a higher incidence of patients with more aggressive prostate cancer if they do have some of these germline mutations. Also, germline mutations are present in a much larger percentage of patients who present with metastatic disease. So the evolving biology of advanced prostate cancer, the take-home points from this consensus was that prostate cancer adapts to the castrate microenvironment, that germline mutations are present in at least almost 12% of metastatic disease, and that advanced prostate cancer harbors clinically actionable molecular alterations, so genomic testing is indicated. So looking at the consensus then in 2019, it was recommended, so priority genes to test for metastatic disease included BRCA2, BRCA1, and mismatch repair genes. BRCA2 was recommended for active surveillance discussions, and screening should be started at an earlier age for patients who had family members who were diagnosed with metastatic disease or more aggressive disease at an earlier age. And so then, this is my final slide. So how can we as nurse practitioners and physician assistants and also nursing or ancillary staff help with treating these patients? We're going to monitor their labs, we're going to order their scans, administer treatments, and manage the toxicities thereof, and then refer to oncology when indicated. And that allows more time for our urologists and our surgeons to spend time on patients who are going to benefit as well. So I'm going to turn it over to Dr. Ed Trabolsi, and he's going to cover bladder cancer.
We're going to hold questions until after all the presentations have been given.
Thanks, Annie. Good morning. Thanks for coming out. My name is Ed Trabolsi. Let me just ask, so as Kostas mentioned, we've been given this course for several years. It started specifically for APPs, and now has become sort of a general course. How many of you in the audience are providers? So pretty much everyone. And how many are physicians? And how many are NPs? And how many PAs? And am I missing any categories? Any nurses, MAs? No. Okay. So it helps us as we try to keep the course, sort of current, to know who actually is coming to the course. So that helps us a lot. Thank you. So I'm going to tackle a nice small topic, bladder cancer. And then so I'll talk about some of the epidemiology, and then basically similar to prostate cancer by disease state. So non-muscle invasive disease, muscle invasive disease, metastatic disease. And as crazy as it sounds, bladder cancer is kind of an exciting space right now. It's, similar to prostate, there's been a real explosion of different treatment options. I did my residency, about 25 years ago, and there really wasn't that much to offer these patients, and now we have quite a bit. It's a big burden on the U.S. health system, estimated about 80,000 new cases per year, about 17,000 deaths per year. It's the fourth most common malignancy in men, with a much stronger male to female predilection, probably due to different smoking rates between men and women, and then also different rates of industrial exposures. And it's kind of an unusual cancer because there's a much higher prevalence than incidence. So there's a lot of people out there living with bladder cancer, fortunately not dying from it. So that makes it one of the most expensive cancers that we have to deal with. At presentation, walking in the door, most patients, fortunately, have superficial disease, but there's definitely about 20-25% that are invasive right off the bat, and then a smaller subset that are metastatic. And it's a disease of the older patients. The average age of diagnosis is about 68. So with all of these different terms, it can get a little bit confusing. And so we try to define what our terminology is. So we have low risk, high risk, and muscle invasive disease. So low risk, non-muscle invasive bladder cancer, AUA actually has a nice table helping risk stratify patients. And these are patients with superficial, non-invasive tumors that histologically don't look very aggressive. The high-risk non-muscle invasive bladder cancer patients are the ones that don't show any evidence of invasion of the muscularis propria, but we're very worried that they may progress to that. So that's the high-grade tumors, the larger tumors, the superficially invasive tumors, and then CIS. And then, of course, we have muscle-invasive disease. So starting with the superficial non-muscle invasive bladder cancer, this is the AUA risk stratification that I was talking about. And this is very helpful. Anne mentioned the NCCN guidelines. So I typically will have NCCN guidelines on my desktop when I'm seeing patients. I'll have AUA guidelines selectively as well. And this kind of looks like the New York City or maybe the Chicago subway map. It's a little confusing, but what we're trying to do, we risk stratify, oops, wrong button. Let's see if this works. So we use low, intermediate, and high risk, and what we're trying to avoid is cystectomy. So we have a lot of different treatments to try to avoid cystectomy. That's sort of the nuclear option. It is something we need to consider, but luckily there's been an explosion of treatments to try to mitigate the need for radical surgery. Intravesical therapy is the primary treatment for superficial bladder cancer. We use it perioperatively, so after the initial biopsy or resection, there's strong evidence that giving an intravesical chemo treatment shortly after the biopsy can help reduce the recurrence risk. This is typically mitomycin or gentamicin. And then the old line standard of care for the last 50 years for reducing both progression and recurrence of superficial bladder cancer is BCG. So that's the one of the first forms of immunotherapy, and this is given in our office intravesically. We also have intravesical chemotherapy induction options, not just a single post-op dose, and that's gained more importance with the unfortunate sporadic BCG shortages. But BCG definitely remains the gold standard. When FDA is looking at new agents, they always want us to compare it to BCG or to have failed BCG, because everyone recognizes, at least at the current state, it is still the best agent to reduce the risk of recurrence and more importantly, the risk of progression. It's generally tolerated pretty well. Flu-like symptoms, irritative voiding symptoms. But you can get systemic BCG infection very, very rarely. And it's also because it's an immune therapy, there's also strong rationale to periodically continue to stimulate the immune system. So maintenance therapy also has been demonstrated to improve and prolong the responses. How does it work? I'm not sure if anyone really knows. There's a lot of different mechanisms that have been thought using both innate immunity and adaptive immunity. So the simplistic way I think about it and the way I explain it to patients, it's kind of like you set a forest fire in your bladder and your body puts out the fire and gets rid of any tumor cells that might be in there. It's kind of simplistic, but it helps explain it. Certainly cytokines have a very important mechanism of action. We think that's one of the ways it works, and there's been some innovative combination clinical trials looking at different cytokines in combination with BCG. Probably about 15 years ago was using a lot of BCG together with interferon. That's kind of fallen off. A typical induction treatment is weekly for 6 weeks, and then maintenance would be 3 treatments at 3, 6, 12, 18, 24 months. Some patients will push past 2 years, but lately with the BCG shortage, we've really cut down on the maintenance. And reduced dosing does seem to offer benefit. So in the shortage situation, or if patients are having a lot of irritative symptoms, you can certainly dose reduce for those patients as well. And there's been several different studies trying to clarify how important the dose is, and you can see here the reduced dose and maintenance. And the bottom line is that any BCG is better than none. If you can give full dose and if you can give all the maintenance, that's probably the best. It's not always in our control. The AUA has a very important white paper or position statement on the BCG shortage, and this does incorporate risk stratification. So the first line there is very important. We shouldn't use BCG for the lowest risk patients. We really should save it for the patients that need it. Moving on to more definitions, defining failure, so recurrences after BCG. We used to use the term BCG refractory. We're trying to move away from that and be a little more specific. We also introduced, NIH introduced the term of adequate BCG. So you really shouldn't say someone failed BCG if they haven't gotten an adequate dosage of it. And so typically, adequate BCG, and this is written into a lot of the current ongoing clinical trials in this space, is 2 induction courses of BCG, so that's 2 6-week courses, and then typically of the 6 weeks, you'd want them to get at least 5 of the 6, or induction plus 1 maintenance, and again, that would be 5 of 6 of the induction and 2 of 3 of the maintenance as a minimum. And now we're trying to parse out a little bit more accurately what we would consider failure. So we do still have the term BCG refractory, but we're trying to really limit that to patients that have persistent high-grade non-muscle invasive disease after 6 months who have gotten adequate BCG. So they've never been disease-free. So you do their biopsy, give them BCG, scope them in 3 months, they have disease, give them more BCG, 6 months, they still have disease. They're not responding to BCG. BCG relapsing is patients who do get disease-free and then have a later recurrence after BCG. BCG intolerant is that subset of patients who don't tolerate and can't get the BCG either from urinary symptoms or systemic infection. And then BCG unresponsive, that's kind of taking the new terminology of what we used to call BCG refractory. That is a combination of different patient populations of the BCG refractory and the BCG relapsing. So these are patients who get adequate BCG and have recurrence within 12 months, specifically for patients with CIS, or within 6 months if they have papillary disease only. The reason we sort of pay attention to these definitions is that this is baked into clinical trial design as mandated by FDA, and consequently, FDA will look for these schemas before they'll give approval for new agents. Salvage therapies after BCG, there's been a lot of different things tried, usually chemotherapeutics, so valrubicin, gemcitabine, mitomycin, docetaxel, and they're mostly small retrospective studies, not great responses, but they do have responses. And so that is for the patients who really will not tolerate or refuse a cystectomy. We can start thinking about some of these agents. Getting back to the single-dose postoperative chemotherapy, mitomycin traditionally was the agent given, and then more recently, SWOG did a trial of postoperative gemcitabine, and that, in our practice, has become the standard. It's definitely better tolerated. Mitomycin really seemed to have more significant postoperative urinary symptoms. Also seemed to get calcification of the scar that patients sometimes would feel. Gemcitabine seems to be better tolerated. So this is something that you need to work into your workflow. Not every operating room has a chemo pharmacy. So with my patients, I operate at different locations. I have to be strategic on the ones that I think I might want to give gemcitabine to postoperatively in terms of where to do their procedures. And then in the non-muscle invasive space, there is data and there is an FDA approval for the immune checkpoint inhibitors for high-risk non-muscle invasive bladder cancer, namely pembrolizumab, and we'll talk more about pembrolizumab later. This was approved about 3 years ago, and this again is for BCG unresponsive high-risk non-muscle invasive bladder cancer, both for CIS with or without papillary disease. This is the Keynote 57 trial, 148 patients, and actually had a really decent response rate, complete response rate of 41%. It's a little bit of a departure from the typical workflow. It has not really picked up very much. Urologists are not typically going to give systemic pembrolizumab, and they're also maybe less likely to share their patients with a med-oncs, but it is something you need to be aware of for the superficial bladder cancer patients. And then also recently, nadofaragene or Astellas, that was reported out probably about 2 years ago, a positive trial, and then for a variety of reasons, took a while to actually get FDA approval, but it was recently approved in December 2002. This is a recombinant adenovirus that actually, it's a form of gene therapy, delivers the human interferon alpha 2b into the bladder epithelium, and so it ramps up interferon production. And this showed significant improvement in the BCG unresponsive patients. When you look at the efficacy analysis of Astellas or nadofaragene, you can see here the complete response rate out to 12 months for CIS of about 24%, and for papillary disease only about 43%. Not a home run, but still another option to offer patients who refuse or can't tolerate a cystectomy. As we get into worse disease, as you can see here, muscle invasive bladder cancer, these are the patients that really are at the highest risk of death of disease. These are the patients that we are maximally aggressive to try to offer them the best chance for cure. So these are patients with T2 disease, meaning invading the muscularis propria, or T3 disease, going through the muscularis propria into the perivesical fat, either microscopically or grossly. These patients need to get very intense surveillance scans for staging. And this is an area of need. We don't have a PSMA PET type scan for bladder cancer yet, but because conventional imaging, unfortunately, very commonly understages patients. And these are patients that really, cystectomy should be considered unless the patient will not tolerate it. If not, you can switch to chemoradiation. In the US, the general practice pattern is to be aggressive surgically. Overseas, in Europe and other places, they tend to view chemoradiation more equivalently to radical cystectomy, but that's definitely a practice pattern variation. So the role of neoadjuvant chemotherapy became defined through a SWOG study several years ago. This was the Grossman study, and this looked at patients with muscle-invasive bladder cancer that are scheduled for a radical cystectomy, and then they looked at whether giving preoperative chemo, neoadjuvant chemotherapy, and then followed by surgery versus upfront surgery improve things. And this is based on the unfortunate, fact that even with aggressive surgery, probably upwards of 40% or more of bladder cancer patients will recur. So it's an area of unmet need to try to improve cure rates. And here you can see that preoperative chemotherapy offered us an astounding improvement in overall survival with early separation of the Kaplan-Meier curves, a 2.6-year overall survival benefit. Another important observation from this trial is the finding of no residual disease in the radical cystectomy. And this was significantly higher, no surprise, in the patients that had preoperative chemotherapy. Now, there are patients with an aggressive TUR where you take their bladder out and you don't find any cancer left, but you could see more than doubled the PT0 rate, and the patients who had pathologic downstaging definitely appeared to do the best. There's been several other phase 3 studies of neoadjuvant cisplatin combination chemotherapy after this seminal paper by Grossman in 2003. We were fortunate enough to participate in a trial together with Fox Chase looking at dose-dense or accelerated MVAC prior to surgery, and they've also done trials of gemcitabine and cisplatin prior to surgery, all of which show similar benefits. The medical oncologists will shout from the hilltops that this should be the standard of care. Unfortunately, it's not really become as widespreadly recommended across, especially in the community, probably because the chemo is fairly toxic. And that's where dose-dense or accelerated MVAC can really help out. This is the schema of the dose-dense MVAC that has been adopted at Jefferson and a lot of places as a standard of care. The nice thing about it is that it's well tolerated. It's 3 cycles given every 2 weeks. And so it also builds in a much shorter delay from the initiation of treatment to eventual surgery, which we do worry for the non-responders that we're delaying their surgery. And you can see here in our small multi-institutional trial a very similar PT0 rate of 38%, and over half of the patients were downgraded to less than T2 disease, which we consider a positive effect. So we always sort of debate, when to give chemo and why would you give chemo pre-op as opposed to post-op. Can't you just take the bladder out, see if it is a high-risk tumor, if it's in the perivesical fat, if it's in the lymph nodes, then give chemo. And this is a slide from Jeannie Hoffman, sent it at Hopkins. And this is her description of what patients look like walking in her door pre-op and post-op. And so the sequence really does matter. It's much easier to give chemo and then go to the OR as opposed to the opposite, where we take their bladder out, get a horrible path report, and then try to get chemo. So we try not to miss an opportunity whenever possible. Adjuvant chemotherapy should not be ignored. There are certainly advantages. You have a more accurate risk stratification, There certainly may be over-treatment of some patients with neoadjuvant chemotherapy who may not need it. But if you look at mostly retrospective pooled data, about a third of patients will not ever be fit enough to get chemotherapy. And this really does lack level 1 evidence, whereas there's been several prospective randomized trials in the neoadjuvant strategy showing benefit. There was a trial trying to compare pre-op versus post-op chemotherapy. Unfortunately, it did not accrue and had to close early, so that was a lost opportunity from Europe. It did, however, show that there seemed to be benefit in patients who got chemo first as opposed to chemo later. So if we look at the guidelines for muscle-invasive metastatic bladder cancer, there are some key recommendations from ASCO, and I pulled out 2 of them. Neoadjuvant chemotherapy is recommended for muscle-invasive bladder cancer, should always be combination cisplatin-based chemo. So carboplatin is not a sufficient substitution. And then in the metastatic patients, the same sort of schema, combination cisplatin-based chemotherapy should be first-line therapy in patients with locally advanced or metastatic disease. I mentioned pathologic downstaging and looking at a variety of the different neoadjuvant trials, and the patients who did get final pathology less than T2 seem to do the best. So if there are patients that have persistent T2 disease, muscle-invasive disease, after chemotherapy, they're at much higher risk of recurrence. Those patients, we definitely may consider other adjuvant therapies for them. Preoperative pembrolizumab has also been investigated, so patients, similar type schema, muscle-invasive bladder cancer patients maybe who can't get cisplatin combination chemotherapy. This is the PURE-01 study. This looked at preoperative pembrolizumab. This was a phase 2 trial. They received 3 cycles, 3 weeks apart of pembrolizumab, and then went on to surgery. And surprisingly, maybe not surprisingly, almost the exact same pathologic T0 rate, 39%, and these patients seem to do well. So this is another potential option in the neoadjuvant space if they can't tolerate cisplatin. Moving forward to metastatic urothelial carcinoma. Immunotherapy has kind of taken the world by storm, and this is an observation that the interplay between PD and PDL, so programmed death and programmed death ligand, it's a very blunt name, in the interaction between T cells and tumor cells, that interaction, if you can augment or alter that, can lead to the body's own immune system taking care of residual disease. The simplistic way I think about it is that we have the brake and the gas pedal, and what you want to do is take the brake off the immune system and step on the gas and rev it up. And this is where trying to impact the T cell antigen linkage, and this is where PDL, PD-1 inhibitors, and the CTLA-4 inhibitors can come into play. And so it's very complicated immunology, and you can see here there's multiple potentially targetable agents, CTLA-4, PD-L1, OX40, and you basically using different antibodies to try to block the effect, either block the inhibition of immunology or block the brake and allow the gas pedal. If you look at the NCCN, principles of systemic therapy. So first-line therapy for locally advanced and metastatic urothelial carcinoma, as I mentioned earlier, for those patients that are fit for cisplatin, similar to the ASCO guidelines, they really should get combination cisplatin-based chemotherapy, either MVAC or gemcitabine cisplatin. For cisplatin ineligible, this is where we will sometimes think about gemcitabine in combination with carboplatin, knowing full well that the response rates are worse. pembrolizumab, as I mentioned, and then there's a bunch of other different agents that can be considered. But those patients, unfortunately, the cisplatin-ineligible metastatic bladder cancer patients, unfortunately, have a very poor response rate and overall survival. The definition of cisplatin-ineligible is not necessarily straightforward. We certainly look at creatinine, and serum creatinine is an estimate. We tend to be very aggressive with 24-hour urines to try to get the most accurate picture of their overall renal function. Performance status is also vitally important. This is toxic chemo. If they're not able to get out of bed, they're not going to do well. And then other specific contraindications, mainly based on the cisplatin side effects, hearing loss and neuropathy. If they have pre-existing hearing loss or neuropathy, those patients can be miserable with cisplatin, and we typically would avoid it. If you look at this, in general, very old, frail, comorbid patient population, a significant number of them would fit the definition of cisplatin ineligible, unfortunately. So I mentioned at the beginning that it's kind of exciting. There's been an explosion of different treatment options. So my residency and fellowship is sort of right in the middle of the first two goalposts in the late 90s, early 2000s. Cisplatin was approved in the late 70s. Gemcitabine was approved in the mid-2000s, and that whole time in between, there really was nothing new for metastatic bladder cancer patients. And then in the last 10 to 15 years, we've had just one new treatment after another. When we look at the advanced bladder cancer landscape, for the platinum ineligible, certainly cisplatin is the backbone, and then we also have PD-L1. But the platinum ineligible patients really is an area of unmet need, with response rates in the 20% range. And so when we're looking at metastatic or advanced urothelial carcinoma, we really are immediately deciding if they're chemotherapy eligible or not. And then if they're cisplatin eligible or cisplatin ineligible. And unfortunately, as you can see, if they're not chemo eligible, we're really not offering them much, unfortunately. Oh, this slide didn't come out too well. I thought I fixed this. I apologize. So this is Javelin Bladder 100. And this is another attempt to try to figure out the best combination. So we have all these new agents. How do you put them all together? And so this is a phase 3 study looking at metastatic urothelial carcinoma patients who got first-line cisplatin combination chemotherapy or carboplatin chemotherapy. And then were randomized after chemo to one of the PDL immune checkpoint inhibitors, avelumab, or best supportive care alone. And this looked at overall survival and progression-free survival. So they get chemo, and then they get put on maintenance immune checkpoint inhibition. And this actually showed significant benefit. So this has become the new paradigm with overall survival benefits, combining post-chemo immune checkpoint inhibition. Going back to the NCCN guidelines, this is for second-line systemic therapy. And you can see it's complicated, but at least we have some options here. Looking at immune checkpoint inhibition, second-line chemotherapy regimens, and then there are some new targeted treatments as well. So here you can see, let me see, I thought I moved a slide, but I didn't. I apologize. So we're going to talk later about erdafitinib and enfortumab, and there's a new one that I can't pronounce that's another antibody drug conjugate as well. Another observation that has been found is that for metastatic urothelial carcinoma, there is a significant number of those tumors that have alterations in the FGFR receptor. That's the fibroblast growth factor receptor. And they do have a target for that, and that's erdafitinib. And so we'll talk about that later. We can see here that several different trials looking at second-line treatment. Unfortunately, 2 of the trials over here were positive in the phase 2 and were approved, and then subsequently their phase 3 were negative trials, and so the FDA withdrew approval for atezolizumab and durvalumab for second-line treatment in this patient population. This is the one that I can't pronounce. If anyone wants to tell me, sacituzumab govitecan. This is an antibody-drug conjugate. So this is an antibody targeting a antigen that's very commonly upregulated in advanced bladder cancer. This is trophoblast cell surface antigen, or TROP2. And this is combined with a cytotoxic chemotherapy. So it's a targeted therapy specifically for this cell surface receptor. And this was, sort of end of the line, multi-lines of treatment patients, failing chemo, failing checkpoint inhibition, and actually had a 27% response rate and a 5% complete response rate. Everything disappeared. So when we talk about the landscape of advanced bladder cancer, if we start with 100% of patients with advanced metastatic, only about half of them get the best first therapy, cisplatin combination chemotherapy. Only a fraction of those patients get second-line therapy, and a tiny proportion get third-line therapy. So unfortunately, utilization of these agents has been slow, and these patients really are in dire straits. Looking at second-line therapy, and there's been a lot of excitement in trying to pick out and identify new targets. I'll also talk about enfortumab as well. But enfortumab is another antibody-drug conjugate. Erdafitinib is the FGFR inhibitor, and then the other antibody-drug conjugate, as I mentioned. If they fail that, and we're not going to put these patients on hospice, then typically we would think about single-agent chemotherapy, perhaps just docetaxel monotherapy, really just for symptom improvement. Lots of different targetable, druggable aspects in the pathway. So there's finally a lot of exciting research going on in bladder cancer, which was not done in the past. And these are some of the trials, and this is, we identify agents that appear to work as monotherapy in the worst patients. Then, of course, we then try to move it earlier in combinations to see what we combine to try to improve response rates. And this, I apologize, I thought I moved the slide up, but erdafitinib is the oral FGFR inhibitor. This is approved for second-line metastatic disease. They have to have FGFR alterations, so that's a tissue diagnostic. And this had an overall response rate of 32%, very small, but there were some complete responses. Enfortumab is another antibody-drug conjugate targeting Nectin-4. That's another cell surface molecule upregulated in about 83% of bladder cancer. This was approved for third-line metastatic urothelial carcinoma. And then actually, in the last 3 weeks, it was recently approved in combination with pembrolizumab for first-line therapy for cisplatin-ineligible patients. So again, moving something earlier to help that area of need. And then I just have a couple slides about upper tract urothelial carcinoma. So the vast majority of urothelial carcinoma is bladder cancer, probably 90-95%. But there are patients who develop primary upper tract urothelial carcinoma. It's uncommon. It's typically patients that have had previous bladder cancer and then recur or progress up the ureter to the kidney. We sort of extrapolate from the bladder cancer data because it's the same tissue type, it's the same urothelium. We don't necessarily have level 1 evidence to prove that the same treatments that we give for bladder cancer are also appropriate for upper tract urothelial carcinoma. Jeannie Hoffman-Sensitz, through ECOG, did do a neoadjuvant MVAC trial, so similar to neoadjuvant chemo prior to cystectomy, giving neoadjuvant chemo prior to nephroureterectomy for upper tract disease. And this is a little bit more controversial. It's a rare disease. This was not a very large study, but we do need to keep in mind that for that specific condition of upper tract urothelial carcinoma, where they're going to get a nephrectomy, where they're almost certainly going to be cisplatin ineligible post-op, that might be a window where we can try to give them chemo that they would never be able to get post-op up front. And then the POUT trial also looked at post-operative gemcitabine cisplatin or gemcitabine carboplatin, so adjuvant treatment for these patients also is in the armamentarium. And with that, I will thank you.
All right, so we're going to move ahead to renal cancer or kidney cancer. Starting with overview, epidemiology, not as common, 2 to 3% of all cancer deaths in the U.S. each year. It's a cancer of a little bit later from an age standpoint, the 60s and 70s decades in both men and women. It's increased by 2% per year over the past 65 years. Most of the tumors are renal cell carcinoma. Most of those are clear cell. Stage really dictates survival, with high survival in stage 1 disease and very poor survival in stage 4 disease. There are some pre-existing factors, smoking and obesity. Certainly there are hereditary types of renal cell carcinoma, which I'll mention a little bit later. And surgical resection really remains the only effective therapy for a localized renal cell carcinoma. So the 2022 kidney cancer statistics, new cases for both men and women. Now, one thing about this is they do lump together both cancers of the kidney and the renal pelvis, so kidney cancer as well as urothelial cancer, although what Ed did just mention is that the incidence of urothelial cancer or upper tract urothelial cancer is quite small. So most of these cases really represent renal cell carcinoma cases, and it's in the top 10 for both men and women in 2022. However, when looking at mortality, kidney cancer falls out of the top 10 for both men and women in 2022. This is a slide that kind of mirrors what I mentioned earlier. So the age of diagnosis or the decade of diagnosis for most renal cell carcinomas are kind of in the late middle age, like 60s and 70s in both men and women. Again, it is a very heterogeneous disease. When we look at the how we divide it up, there's clear cell and non-clear cell, so that's really how we like to define kidney cancer in general. As I mentioned, clear cell is the most common histology, although papillary, which is the second most common, at one time was split into type 1 and type 2. However, more recently, we've lumped together both type 1 and type 2 into a single papillary renal cell carcinoma. The third most common type is the chromophobe renal cell carcinoma, which mimics oncocytoma. They come from the same nephron or part of the nephron, although chromophobe is considered malignant and oncocytoma is considered a benign tumor. And then some other benign tumors are mentioned down below. Although, as I said, over 90% of all metastatic renal cell carcinoma is the clear cell variant. So this is what it looks like under the microscope. Again, clear cell, which is the most common type of renal cell carcinoma, has that really distinct clear cytoplasm. It is associated with von Hippel-Lindau disease. Papillary disease has been now lumped together, although this is what type 1 and type 2 looked like respectively. With type 2, you saw a lot more eosinophilic cells. However, they both have that papillary, finger-like, frondular histologic appearance. So that is what we look for when we are defining papillary renal cell carcinoma, and both of those also are associated with very specific mutations. Getting into chromophobe and oncocytoma, although it doesn't really appear that way on this slide, under the microscope they can actually very, very similarly mimic each other, and it can be very difficult to tell one from the other, although our GU pathologists at our institution are very good at not just detecting it by H&E staining, but using even more advanced immunohistochemical staining in order to tell one from the other. Both of them can actually be present in Birt-Hogg-Dubé syndrome, and I have a couple patients with Birt-Hogg-Dubé who have both chromophobe renal cell carcinoma and oncocytoma. As far as the staging goes, again, staging really dictates the survival with renal cell carcinoma. Staging is done by tumor size. 7 centimeter is the cutoff for T1. Above 7 centimeter, but organ confined, is T2. And then regardless of size, if it's a locally advanced tumor which goes through the capsule of the kidney, either into the perinephric fat or into the renal sinus, that's considered T3 disease, and contiguous structures is T4 disease. Looking at the survival, again, I kind of mentioned this earlier, localized disease, that is going to be the highest stage of presentation and the highest survival. So, and then locally advanced disease is this. So this is T3 disease. We do still have some success there. And then with distant metastases, then you're seeing a much more poor survival. And what's been taught to us over time is that approximately a third of all renal cell carcinoma is metastatic at presentation. Unlike urothelial carcinoma, which is a chemotherapy responsive tumor, renal cell carcinoma is really not. There have been 83 trials lumping 4,000 patients together with an overall response rate of really only 6%. And these are some of the agents that have some activity against renal cell carcinoma, but in general, these are used in very, very, very small select circumstances, or really not at all. However, we have been doing better with renal cell carcinoma over the decades. From a 1 year and 5 year survival, the curves, although it's difficult to tell with this just because it's so spread out. However, when you look at the first point and the end point in both of these curves, you see about a 10 to 20% improvement in survival for renal cell carcinoma over the years, which tells us that we are certainly doing better. Renal cell carcinoma is also considered a very immunologically responsive tumor. Believe it or not, spontaneous remissions have been documented. Also, a very hardy abscopal effect is associated with renal cell carcinoma, where you remove the primary tumor and you can actually see regression of metastatic disease. There is an increased risk of these cancers in patients with immunodeficient states, either HIV or patients who are transplant recipients on immunosuppressive medications. And these tumors certainly are seen to harbor a significant amount of tumor-infiltrating lymphocytes, which again points to their immunogenicity. So I'm going to go a little bit different than what Ed did. Ed started with local disease and went to metastatic disease. However, when you consider systemic therapy for kidney cancer, really metastatic disease, at least for a while, is what we were looking at. So, and I got this slide actually from one of our medical oncologists, Dr. Zarabi, who's at Jefferson. And this is the way that he looks at metastatic kidney cancer, right? And I think that it makes a lot of sense, which is why I included it here. So his first step is to risk stratify these patients, and he uses the IMDC risk model. And the actual characteristics or the variables that he uses are listed in the table below. And patients, and looking at the Kaplan-Meier curves to the right of that, patients with better risk disease do better. Patients with poor risk disease do worse. So this is why it's important to risk stratify these patients. Another thing about risk stratification, again, using that IMDC model, is that looking at the variables as they're listed, about 80% of patients who present with metastatic renal cell carcinoma actually harbor intermediate or poor risk disease. So the majority of these patients who are showing up with metastatic disease are going to be poor intermediate or poor risk off the bat and aren't going to be eligible for some of the regimens which actually are intended for patients with better risk disease. So now that we've risk stratified our patients, the next step that Dr. Zarabi would like for us to consider is, should we remove the primary tumor? And now this is radical when you think about it. And you're looking at the studies which are below, which is a combination of the SWOG and EORTC studies, which were published back in 2004, using patients who received actually interferon alpha. And the conclusions of those studies is that cytoreductive nephrectomy offered a survival advantage, really, really dramatic, and the highest benefit was in patients who actually had a better performance status. They reported minimal surgical complications. Now, the problem is that at the time we thought this was really more or less of a modest benefit, and it took a long time to actually accrue these patients, so it was a very heterogeneous population. However, I think the biggest point that needs to be considered when looking at those two studies is that nearly all the patients who were enrolled in those studies actually received systemic therapy. However, those studies drove our practice patterns for at least 10 to 15 years. So everybody's showing up on our doorstep with metastatic disease. If we thought we could get it out, we were getting it out. Right? And I think that we hurt a lot of patients in doing that and actually may have prevented them from actually getting to systemic therapy, which brings up this next point. We learned, unfortunately, the hard way that we were performing cytoreductive nephrectomy actually in the wrong patient. And there are, on the left, I mentioned tumor-specific variables, and on the right, patient-specific variables on why we should not be performing cytoreductive nephrectomy on these patients, but we didn't have the level 1 evidence that they had back in 2004 until this. This is the Carmina and the Surtime trials that just were recently published within the last 5 years. They were designed a little bit different, but both were looking at strategies of cytoreductive nephrectomy upfront versus systemic therapy upfront, and what was the ideal way to actually treat these patients who are showing up with metastatic renal cell carcinoma. So the first trial that I'm showing is the Carmina trial. Patients were randomized to actually receive nephrectomy followed by sunitinib versus sunitinib alone. And it was a non-inferiority trial. And as you can see, actually the survival curves actually very much mirrored each other. So this is actually the Surtime trial, again, designed a little bit differently. However, it was also looking at systemic therapy versus nephrectomy, with the patients who received systemic therapy up front actually receiving a nephrectomy down the road. And I like the design of this trial because what it allowed us to actually do with these patients is that those patients who were seen to progress on systemic therapy, as opposed to jumping into nephrectomy at that point when they probably were doing very, very poorly, it allowed for us to administer a second-line systemic therapy in these patients, right? So in other words, you would select out those patients who would do best with cytoreductive nephrectomy versus those patients who may do better with a second systemic therapy, and by doing that, you would improve the ability to toggle those patients who failed upfront systemic therapy to get a second systemic therapy and actually improve their survival. So in looking at it this way, after Carmina and Surtime, should we remove the kidney or the primary tumor in patients who present with metastatic renal cell carcinoma? The answer is not really necessarily, especially for patients who are poor risk or high risk tumors, or those patients with a very, very poor performance status. Again, this slide doesn't show up well. However, what do we know regarding cytoreductive nephrectomy in 2023? It really only improves survival if systemic therapy is delivered. Not all patients who undergo cytoreductive nephrectomy unfortunately receive systemic therapy, and not all patients who undergo cytoreductive nephrectomy really require systemic therapy. And I think that the Carmina and Surtime really has changed how we look at this. These are the NCCN guidelines. which shows that patients who would be candidates for cytoreductive nephrectomy, in other words, if we think we can safely remove the tumor, these are the patients who should be getting it, whereas those patients who show up with very bulky disease, very bulky adenopathy, a large tumor burden outside of the actual kidney, those are the patients who we should be considering for upfront systemic therapy. So now we've risk stratified our patients. Now we've considered a cytoreductive nephrectomy in our patients. And then the final question is, do we really need to start systemic therapy immediately? And this has been looked at actually in some smaller phase 2 trials. However, the answer is we don't necessarily need to, because, and I see our medical oncologists doing this more and more, they'll have a patient with a minimal amount of metastatic disease who may receive an upfront cytoreductive nephrectomy, and they're not going to jump into systemic therapy with these patients. They're actually just going to follow them. And as a result, these patients may be, because they're not receiving systemic therapy, their quality of life is going to better. So actually you can define a subset of patients who you don't necessarily need to start systemic therapy on, even though they're presenting with metastatic renal cell carcinoma. Again, kind of changes the way that we look at metastatic disease currently in patients who present with metastatic renal cell carcinoma. So Ed showed his own slide of where his residency lies in the treatment regimen, or the treatment timeline for metastatic urothelial cancer. This is kidney cancer, right? So there's the cytokine era, right, which was kind of the Iron Age of treatment, and our residencies were in here, and then after we finished our residencies came the targeted area, which I'm going to show. However, with the cytokine era, here's the NCCN guidelines, and I'm not going to bore you with this. Really, only interferon alpha and IL-2 were mentioned in the NCCN guidelines, and when I was a resident, this was all that we had to administer to these patients. IL-2 was really, really toxic. And interferon, if you remember, that was the agent that they showed in those patients who received the cytoreductive nephrectomy, so those trials back in 2004. And then came the targeted era, which is the more modern era that just ended back in 2015. The highlight, or the underlying principle of the targeted era, was the elucidation of the VHL suppressor gene. So tumorigenesis is dependent on mutation of the VHL tumor suppressor gene, which is really present, again, in 90% of patients with clear cell renal cell carcinoma. So in a normal individual, VHL encodes for the ligase that targets HIF, and in a mutated gene, you get an overexpression of HIF, which drives all of these other factors here, namely VEGF, which are drivers of angiogenesis, and that leads to actual tumor formation. And I pointed out VEGF because when considering VEGF positive versus VEGF negative tumors, there is actually a decreased survival in those patients with VEGF positive tumors, which again are likely those patients with clear cell renal cell carcinoma. So that principle alone drove the research that led to the development of all of these agents, which targeted various pathways led by an overexpression of HIF, which is a VHL mutation, and these are the agents which we're going to be talking about at this point. So the first one that was studied, this was published back in New England Journal of Medicine back in 2007, was sunitinib, or Sutent. It was compared against interferon alpha in patients with metastatic renal cell carcinoma. And looking at the forest plot, which is on the left or on the right, sunitinib is on the left versus interferon alpha. So across all groups that were studied, you saw an actual advantage in patients who received sunitinib. However, when looking at the adverse events, and this is really one of the drawbacks of those targeted therapies, so those VEGF targeted therapies, they were very, very difficult to tolerate. And this is the dreaded hand-foot syndrome, which feels just as bad as it looks. I mean, these patients were miserable. So these inflammatory reactions on the palms of the hands and the soles of the feet. They couldn't walk. They couldn't grab anything. It was really, really difficult for them to tolerate, and it was elucidated, at least in this trial. In the same journal that published on sunitinib was this article on sorafenib. Again, this was the article that led to its approval also for patients with metastatic renal cell carcinoma. It was compared to placebo, also was a positive trial. And like I mentioned, this was the advent of the targeted therapy era. So we knew what the VHL suppressor gene did. We knew that there were targetable molecules which we could manufacture or develop drugs against. And these are the studies, most of them phase 3, which led to the development of the drugs during the targeted era. Again, at the time, and I'm going to hit this a few times, the comparator was really the prior era, which was interferon, which had a very, very modest effect anyway. So it was kind of like you were the bully picking on the little kid. One thing that, a study that we actually looked at very, very closely at Jefferson, and it kind of drove our treatment patterns at that time, was the COMPARES trial, where now you're comparing, as opposed to interferon, you're looking at a new agent called pazopanib and comparing it to sunitinib. And this was a randomized trial. Again, patients were randomized to receive pazopanib versus sunitinib, and this was a first-line treatment for metastatic renal cell carcinoma. It was a non-inferiority trial, but looking at the curves in progression-free survival and overall survival, they completely mirror each other, so it shows non-inferiority of pazopanib versus sunitinib. However, I think that the more impressive part of the study looked at the adverse events. Again, this is the forest plot. Looking at pazopanib, most of those side effects you saw, which were seen with patients who received sunitinib, the side effect profile was much less with pazopanib, and it became one of the agents that we used, especially toward the end of the targeted therapy era. And again, these are the agents that were FDA approved at around 2015. Okay, so again, we've talked about the dark age. Here's our residencies. Then became the modern age, which was the targeted therapy era, which ended around 2015. But more recently, we have entered the golden age for the treatment for systemic therapy for metastatic renal cell carcinoma. Although the first agent that I'm going to show there is actually a targeted agent. It's called cabozantinib, but it inhibits many of those targets that I showed on that one slide, where the elucidation of the VHL gene and all the molecules that came from it that drove angiogenesis. Cabozantinib not only hit VEGF, but MET and as well as AXL. So, and it's considered a very, very potent drug, which we actually still use, and it still is in the guidelines for first-line treatment of metastatic renal cell carcinoma. So this was the CABOSUN trial that, again, kind of launched cabozantinib. It was compared against sunitinib, so it's a targeted agent versus a targeted agent. These patients had poor or intermediate risk disease, and you saw cabozantinib outperform sunitinib, again, with the curves separating very early on. So, and as a result of this study, cabozantinib was approved for first-line treatment in metastatic renal cell carcinoma in those patients with intermediate or poor risk disease. However, around the same time came this study, which again was looking at patients who had been pre-treated, so they'd already been on at least a couple targeted agents, and they were going to see how did they do with nivolumab. So it was one of the PD-1 therapies. It was given to patients who were pretreated, published in the New England Journal of Medicine. It was compared against everolimus. Everolimus was one of the targeted agents, and nivolumab outperformed everolimus, again, in this patient population, and showed activity of the target of the immunotherapies in metastatic renal cell carcinoma, and kind of opened the doors to what could be imagined at that point. So on the heels of this came this study looking at combination immunotherapy a combination immunotherapy regimen. So you had nivolumab, which was anti-PD-1. Again, remember the slide that Ed showed you about the checkpoint inhibitors. You added ipilimumab, which is an anti-CTLA-4 molecule, and that was a combination trial, right? So it's a combination regimen, IO therapy, looking at patients first line with clear cell renal cell carcinoma, over 1,000 patients, so pretty good numbers. And it was compared against Sutent, or sunitinib. And again, you saw the combination IO therapy very well outperform from a disease-free and an overall survival standpoint, Sutent. So as a result, Ipi-Nivo, which is, as we know the regimen now, was approved for first-line treatment in patients with intermediate or poor risk metastatic renal cell carcinoma. And I specify poor risk because when you look at this trial, sunitinib actually outperformed the combination IO therapy for patients with favorable risk disease. Again, that 20% of patients who have that favorable risk disease actually, by this trial, benefited more by sunitinib. So at least at this time, sunitinib was still in the NCCN guidelines for treatment of patients with metastatic renal cell carcinoma, first line, who had favorable disease. The other thing that I should mention about this is that when you looked at the tolerability of the combination immunotherapy regimen versus the targeted therapy regimen, I already showed you what the targeted therapies, how harsh it was to these patients. The combination immunotherapy regimen was very, very well tolerated in comparison. So, and we knew that from the bladder cancer as well. These are drugs that are well tolerated with these patients. They do have their own side effects. However, they were thought to be much better tolerated than the targeted agents for patients with metastatic renal cell carcinoma. So now we have two regimens or two drug categories which we know have efficacy against metastatic renal cell carcinoma. The first are the targeted agents, which was that modern age, and the second are the immunotherapies. So the question comes, well, what happens when you combine these? And this is the era that we're in, at least at this point. This was published back in 2019, pembrolizumab plus axitinib. I see it even advertised today at this meeting. This was a trial looking at patients who were untreated. So again, first-line therapy, patients with metastatic clear cell renal cell carcinoma. They were randomized to receive pembro-axi versus sunitinib, looking at overall survival and progression-free survival as their primary endpoints. And the combination regimen significantly outperformed sunitinib for both progression-free and overall survival. Now, when looking at the adverse events, now you're comparing more apples to apples because it's not that combination immunotherapy regimen, but it's a combination regimen with an immunotherapy and a targeted therapy. And you're comparing it against a targeted therapy. So now you're seeing the adverse events kind of more closely approximate each other. So this combination regimen, although you saw more efficacy, you were seeing the adverse events that you saw with the monotherapy targeted agent. Although when you look at it, you're getting a better response with the same side effects, so it's still thought to be a better regimen. And based on this, the FDA did approve pembro-axi for first-line treatment for advanced clear cell renal cell carcinoma. The Checkmate 9 trial looked at nivolumab plus cabozantinib. Again, cabozantinib is that wonder kid from a targeted therapy drug combined with nivolumab, which we already know has activity against metastatic renal cell carcinoma, although that trial was in patients who had received other therapies. This is upfront first-line treatment, and again, randomized against sunitinib, looking at the primary endpoint, which is progression-free survival, with the secondary endpoint being overall survival. And again, you see a dramatic response in patients who received the combination therapy against sunitinib. The curves separate very, very early on, and this led to approval of this. The one thing I will mention is that this, as opposed to the Ipi-Nivo trial, which really only showed benefit in patients with IMDC, intermediate or poor risk disease. The benefit with this trial was across all IMDC risk groups. So when you look at the NCCN guidelines, you're going to see the regimen that I'm talking about here actually across all different IMDC groups, not just the intermediate and poor risk. New kid on the block as far as this goes is lenvatinib. So it was pembrolizumab. Again, this was randomized against, in this case, everolimus. Although this was kind of a three-arm trial, so you had lenvatinib plus pembro versus lenvatinib plus everolimus, which is a targeted agent, again, and then randomizing it against sunitinib. So it was a 1-to-1-to-1 randomization. And this was the Kaplan-Meier curves as a result of it. And looking at the forest plot that's shown on the right is actually the combination targeted therapy with immunotherapy regimen versus Sutent alone. And again, along all IMDC risk groups, along all substratification, you saw a benefit of this regimen versus Sutent. And it actually showed benefit over the combined lenvatinib everolimus, which was a targeted agent, actually two targeted agents, where you're again seeing the benefit more of the targeted and IO therapy, the lenvatinib and pembrolizumab. And as a result of this, the FDA did approve lenvatinib and pembrolizumab again in its first-line treatment for patients with advanced renal cell carcinoma. So looking at the NCCN guidelines from April of 2023, so just before this meeting, again, thinking back to what I told you about metastatic disease, you first need to risk stratify your patients, favorable or poor intermediate risk. Looking at favorable disease, although Sutent is still in there for other recommended regimens based on Ipi-Nivo trial, all of the targeted, all of the combination therapies that I mentioned are now considered the preferred regimens, which are immunotherapy plus targeted agents put together. For the poor to intermediate risk, again, you're looking at a lot of the combination regimens, including the dual immunotherapy regimen, Ipi-Nivo, and cabozantinib is still hanging in there, again, as the preferred regimens, and these are other recommended regimens. And then getting down to the second-line treatments, IO therapy naive and prior IO therapy, these are the regimens that we're actually looking at. But again, this is for clear cell renal cell carcinoma. When looking at the non-clear cell histologies, and I unfortunately have been ignoring that a lot here, only because there aren't really many options for it. So still looking at the preferred regimens, cabozantinib, sunitinib, and a clinical trial. So the immunotherapy combined regimens, although they work very well against patients with clear cell renal cell carcinoma, we have yet to really show the benefit in patients with non-clear cell histology, which again can represent for up to 15% of those patients with metastatic renal cell carcinoma. And this is an area really of active research. The last point that I wanted to make with these trials is that most of these combination regimens were compared against sunitinib. We haven't really seen trials that have compared the separate combination regimens. So like I said, I was going to start with metastatic disease, and then I was going to go to localized disease, because there are some new recommendations with regard to localized disease, which I think are worth mentioning. It used to be very easy with stage 1 through 3 tumors. You resect the tumor, partial or complete nephrectomy. It was really at the discretion of the surgeon. Now we're wondering, is there an adjuvant therapy that we can actually give to these patients? And this is the targeted agents looked at in the adjuvant setting for patients with locally advanced disease. Most of those were negative studies, although the STRAC study did show benefit with regard to disease-free survival. It did not show the benefit with regard to overall survival. STRAC looked at sunitinib. We've already talked about the tolerability of sunitinib. So as a result of this, a lot of our medical oncologists really didn't necessarily want to give this drug in the adjuvant setting for patients with locally advanced renal cell carcinoma, although the FDA did approve it. As far as immunotherapies, these are the studies that have looked at it. Some of those studies have come back negative. The Keynote 564 looked at adjuvant pembrolizumab. It did show a benefit with regard to disease-free survival. This is a study. Again, patients were randomized to receive adjuvant pembrolizumab versus placebo. This was the disease states that came in. So large tumors that were localized to the kidney, however, with a very high nuclear grade, locally advanced tumors, patients with lymph node positivity or metastatic disease, and in these last two cases, they were completely resected. The disease-free survival was the primary endpoint. And here are the curves that we looked at. The median overall survival was not reached in either group, although they did show a 32% lower risk of death with adjuvant pembrolizumab. And again, this is intermediate risk, and this is high risk, and these are patients with metastatic disease. So not really the best data. However, it did show activity, and as a result, the FDA has approved adjuvant pembrolizumab in those patients, again, with these disease states, which were looked at in the trial, in the adjuvant setting for patients with renal cell carcinoma. So these are the guidelines. Again, patients with local disease or locally advanced disease and a high-grade tumor. These patients are thought to potentially benefit from adjuvant pembrolizumab, or even down here it mentions sunitinib as part of that STRAC trial. So, but however, again, pembrolizumab is better tolerated, so what we're seeing at our own institution is that those patients who are young with locally advanced tumors who we think may benefit from adjuvant therapy, they're actually more readily going to administer this to these patients, again, because it's tolerated so much better than those targeted agents, and as a result, we think that we may be doing some benefit to those patients. All right, do I need to show the post-test at this point? Do we not go through the post-test again? No. Okay. All right, so at this point, we have a little fun. So I actually brought this back. For the first year that we presented this, we had case presentations looking at prostate cancer, bladder cancer, and kidney cancer patients. So I have cases that we actually saw in our own clinics, and I'm going to call on my panel here today to give their recommendations. The interesting thing about this is when I looked through this, I had to actually modify the cases based on current recommendations, and it's really dramatic how, because of the way that the guidelines have changed, the studies that have come out, the changes that I've had to make in these cases because of new things that are actually available to these patients. So our first patient was presented in 2010 with a PSA of 1.6, had a nodule on his prostate. This is his HPI, past medical surgical history, not really much there. Family, social history. Patient underwent a transrectal biopsy. At that time, he had what was Gleason 5+3 disease, which is now grade group 4 disease. Maximum core involvement was 100%. So at this point, to my panel, what are our staging options for this patient? He has high-risk disease, grade group 4 disease, doesn't really have much of a PSA, but had a nodule on exam. How would you stage these patients?
B and G.
B and G. So CT scan and a bone scan. How old was our patient? I didn't give an age. So if this patient were over the age of 65, how would you stage this patient?
C.
So this raises the question of a next generation imaging. And in NCCN, for patients that are newly diagnosed, high risk or very high risk, and he would be considered high risk with a grade group 4, there is support for doing upfront PSMA PET as the initial staging study. It is not necessarily universally covered, and there's a lot of controversy about the availability of some of the next generation imaging. Sodium fluoride PET is a sort of a super duper bone scan. Had a splash, so to speak, maybe 10 years ago. It's not really around anymore. So depending on the insurance and the coverage, at a minimum you would want conventional imaging, but it would not at all be unreasonable to start with a PSMA PET.
So, and I actually added PSMA PET into this algorithm just because at the time that we came up with this the first time, it wasn't even really available. So we actually did a CAT scan and bone scan on this patient, as we talked about. He had a CT urogram which showed no Mets, bone scans showed no Mets, and so he underwent treatment. So treatment for this patient could have been radiation or surgery. We decided on surgery. He had a robotic prostatectomy. He was upstaged to a grade group, although still actually a grade group 5 disease now, or 4+5 disease, and the pathology was locally advanced with T3A in 0, R0, so negative surgical margins. I guess I should ask at this point, what would we do with this patient at this point? So you have locally advanced disease, grade group 5, youngish patient, underwent a robotic prostatectomy back in, this was 2010. How would we treat this patient now?
So there's a couple different thoughts that come into mind. So certainly there's a role for the post-op genomic testing. The role of adjuvant radiotherapy has really been controversial for many years. At Jefferson, we used to be very aggressive with post-op radiation for any adverse pathologic feature. We've sort of supplanted that with genomics. And so there is a genomics assay available in the post-op setting, Decipher. If they're high risk, Decipher, then we would counsel them in a shared decision-making model about being aggressive with post-op adjuvant radiotherapy versus surveillance.
Right, and so this patient underwent the prior, or the latter, which is surveillance, undetectable PSA. However, about a year after, or a couple years after his radical prostatectomy, now we see a detectable PSA 0.2, 0.1, and 0.2. So this was the next question that I had asked. This was however many years ago. What are you going to do now? What would we do now with this patient?
So this is kind of timely because I heard through the grapevine that EMBARK is going to be reported out this meeting. So EMBARK was a clinical trial of enzalutamide for biochemically recurrent patients after definitive local therapy. The rumor is it's a positive trial. Mm-hmm. And that was randomizing, I don't remember the randomization. Is it ADT alone plus ADT?
It was ADT
with
versus ENZA, right.
For this man, that PSA is so low, next generation imaging probably won't show very much, but you'd think about imaging him to try to clarify whether he has metastatic disease or not. There's also a randomized trial now looking at PET-directed therapy, which is available at Jefferson. So patients, this is through the ECOG cooperative group, where patients with biochemically recurrent disease, they would get an upfront PET, and then depending on what the PET showed, they would intensify or de-intensify the salvage therapy. So if it didn't show metastatic disease, then potentially just salvage radiation. If it showed low volume metastatic disease, you'd get radiation, salvage radiation with radiation of the involved metastatic sites with or without I think apalutamide. So that's another consideration. But this patient, you kind of could have a shared decision making on how aggressive you want to be.
And one of the conversations that's come up, which never really came up before, because a lot of the times we were just tossing these patients to radiation oncology, and they would give salvage radiation to the prostate bed, is could you wait until their PSA gets to a level? Because Ed mentioned this earlier, it's probably still too low at this point that anything's going to show up on a PSMA PET scan. Usually 0.4, 0.5 is what we use as a cutoff to where we think we actually may see something in these patients. So would you just wait until the PSA gets to that point, do a PSMA PET scan, and see what it shows? I mean, if it shows local recurrence in the prostate bed, but again, remember this patient had negative margins, and although T3 disease, so it's actually very possible that this patient is going to recur distant. So it may be worth waiting in these patients, or this particular patient, until his PSA gets a little bit higher, and that can be a very uncomfortable conversation. Although it would be nice if he showed up with like a solitary node or even a solitary bone met to actually target that versus administering radiation to the prostate bed, which has its own side effects. I mean, for those of us who have seen hematuria in these patients, even though time has gone on, that complication certainly hasn't gone away, and it can be very difficult to treat, and it's hard to justify doing that in a patient which you don't think is going to recur locally anyway.
I think it's also important to mention that our old paradigm of bicalutamide probably should be retired.
And
Oh,
there
here we
it
are.
comes. So that's what we did with this patient back in 2000. I mean, this is only 10 years ago. We started bicalutamide, we started Lupron, we gave radiation, and his PSA did respond, although it may have been due to the Lupron. But once the Lupron was stopped, then we saw his PSA really start to skyrocket up. And one thing I will say, in these patients, I am looking at the PSA doubling time. If it's a really, really slow doubling time, again, that's more consistent with a local recurrence. And it's somebody who I may recommend for, well, although this particular patient got radiation, but when you see it start to skyrocket like this, you really start to think of distant disease. I said here repeat staging studies at the time. What staging studies would we get on this patient at this time?
Yeah, so he's gone from a PSA of 0.2 to 1. So, PSA of 1, PSMA PET should be fairly accurate. Again, unfortunately, this sometimes is predicated on the insurance coverage. If it's not covered, then we'd get standard CT and bone scan.
Okay. So, kind of went out of sequence here, but this patient did respond to his radiation. Again, it was undetectable. However, we started to see the PSA go up at that point. And then we come to the staging options, which is what we just mentioned. Really, A through E is what we had available to us in 2017. We had the PSMA PET afterward, and really PSMA PET we think is what we actually may give to this or use on this patient at this point. So now the patient has been placed on apalutamide and Lupron. Did have an Axumin PET scan that was negative. This was actually after radiation. And now we're seeing the PSA start to go up in a patient who was on androgen deprivation and an AR-directed therapy. So PSA has gone from 0.3 to 0.6 to 4 to 12 in a just over over 6 month period. So really, really rapid doubling time. And so we have a patient with castrate-resistant prostate cancer. So what are we going to do with this patient who now we know has a castrate testosterone, although and a PSA that's going up? What is our next move for this patient?
So this is kind of interesting because, and this gets back to clinical trial design and drug development. So apalutamide was sort of a Me Too drug coming into the market after enzalutamide, and they're trying to figure out how to get into the market. So they were smart and looked at the non-metastatic castrate-resistant space, which at that point there was no approved therapy other than ADT, and they showed benefits. So this sequence is exactly that sequence. So now he's got a PSA doubling time less than 6 months, so he's at the highest risk of eventual death from prostate cancer. Have we staged him again?
Good question. So how would we stage this patient at this point? I mean,
So not to be repetitive, but we love our PSMA.
but at the time, all we had was a bone scan and a CAT scan. Also, the bone scan did show osseous metastases in L2 in the right acetabulum. So now we have a patient with metastatic castrate-resistant prostate cancer. So looking at the current guidelines, now these were the guidelines. Looking at the current guidelines, how do you think we treat this patient? So he's already been pre-treated with
second generation
right.
AR. Yeah, so as Ann says, I mean, this is really technically second line therapy with a very fast PSA doubling time. So docetaxel may be a very good option for him. We certainly would want to consider a bone strengthening agent since he has bone mets, denosumab. Sapulacel T is on the list. It's probably underutilized. His PSA doubling time's a little quick, so he's the kind of guy that we might not want to slow everything down just to see if there's any response to that. And then radium-223, I think, would be also approved here as well. So we have a lot of different options for him.
So at the time, we started abiraterone with prednisone. We did give denosumab, like you mentioned. His PSA did respond initially, but again, over a 6-month period, went from 0.6 up to 11. So again, very high risk that this patient is going to die from prostate cancer. We've now tried him on a couple different regimens, all AR targeted. So
this also brings up the observation, sequencing these treatments is so difficult, figuring out where they should go. But it does seem to be fairly consistent that if they've had an AR-targeted therapy followed by an androgen biosynthesis inhibitor, they don't necessarily respond very well, and vice versa. So Enza, Abby, Enza, I mean, it's an option, and some will respond, but you might want to think of another mechanistic target.
So we restaged this patient. Again, we can recreate the wheel and talk about PET scan, but we didn't have that available at the time. We got a bone scan, and now we have a patient with diffuse osseous metastatic disease. So CAT scan, I think, was still negative, so we did not see visceral metastases, did not see adenopathy, but again saw mostly or so almost primarily osseous or bone disease. So he was symptomatic. He received palliative radiotherapy, and this is a patient who we administered radium-2232, completed 6 cycles in October of 18, and his PSA responded a little bit, although started to creep back up again. So now we have a patient who's failed a couple AR-directed therapies, failed Lupron alone, now failed radium-223, and really our treatment options, I think, at this point are becoming more and more limited. I'll go ahead and take this one. I think that docetaxel was what we were going to administer this patient, which we did. And I believe he is still alive. Maybe. So I'd love to go over through the rest of the cases, but we're going to run out of time. I'll take questions at the here at the lectern, just because, just in the interest of time. If you guys do have any questions, again, I thank my speakers, my panel. Thank you to all of you for showing up. I hope you enjoyed it today, and hopefully, again, we can come next year and show all the updates that the last year has brought us with regard to systemic therapy for these GU malignancies.